NIV took off in the late 80s, and until that point in time, mechanical ventilation was considered a technique working in a closed environment. With NIV, we changed totally our attitude, since NIV, by definition, is a technique working in a semi-open environment. Therefore, we needed also to change our attitude towards monitoring, because leaks became extremely important to assess in order to compensate for leaks for a ventilator, and on the other side, in order to estimate the exhaled tidal volume that our patients were developing, since alveolar hyperventilation is extremely important to monitor in this patient, beside all the other physiological variables that you can monitor during NIV. Only a minority of the patient undergoing chronic NIV got severe problem of hypoxia. So the main reason to ventilate a patient is to get rid of a high level of PaCO2. And PaCO2 is a reflection of what we call nocturnal alveolar hypoventilation. And therefore, sleep is a very important issue to tackle when we monitor a patient undergoing home mechanical ventilation. We know that during nighttime, a lot of events may interfere with ventilation. For example, patient ventilator asynchrony, upper airway obstruction, together or not with increased respiratory drive, upper airway collapse, and last but not least, alveolar, as I said before, alveolar hyperventilation. It is very important to assess not only breathing frequency, but also the estimated tidal volume during nighttime. So sleep is not the only moment in which you can and you must monitor the patient, but is probably the most important moment of the 24 hours to closely monitor in this patient. Well, in the era of personalized medicine, I do not think that you need to focus directly on disease, but it's better to focus directly on the patient, irrespective of the underlying disease. In other words, the setting of the ventilators usually is done in the hospital, and then the patient are sent home, and close monitoring may detect any form of potential worsening of the disease when the patient is at home. So I do not think that a specific disease is a real goal, but rather is the patient itself. And there are at least 3 ways of monitoring our patient when they are at home. The first one is the easiest one, is a sort of flow chart of a main physiological variable like tidal volume, the number of breath triggered by the vent and by the patient itself, the synchrony of the patient with the ventilator, and overall the alveolar hypoventilation. The second step is just a sort of close look of a single traces or a series of traces, just to better understand if this number that you saw before had a more physiological explanation. And the fourth and probably most important way of assessing the physiological variable is feeding in the ventilator, for example, some belts to assess the patient ventilation asynchrony during nighttime, and eventually some way of recording gas exchange like oximetry and end-tidal CO2 or transcutaneous CO2. Altogether, these 3 different ways of monitoring the patient may be very useful in detecting any problem when the patient is at home and also clearly in the hospital. Well, as I said before, I think in the ideal world you should monitor the patient every time is connected to the ventilator, because this is the way that you can assess first the compliance of the patient to the ventilator, because we know that not all the patients are very compliant to this technique. The second is eventually, if you have the option, you see gases change. As I said before, patient ventilator synchrony and alveolar hypoventilation. So I think that the more we monitor the patient, the best is not only for us as a clinician, but also for the patient itself to early detect potential worsening of disease. In this way, we can probably prevent an acute exacerbation of a disease, and we can avoid eventually the hospital admission and save money at the same time.